Good morning. Uh, okay. Yes. So, whenever we see this kind of a picture on the first or any time after the cataract surgery, it is of great concern to us because this definitely shows that something has gone wrong in this thing, and no cataract surgeon or any surgeon would like to see acute postoperative endophthalmitis, which is the most devastating complication that we can get in cataract surgery. So that we don't have to see this, to prevent all these infections, we have designed this instruction course where we are going to walk you through right from the start, at the beginning, how to build an ideal ophthalmic theater, then how you do the cleaning and sterilization of it, how do you monitor and do surveillance to see that your cleaning and sterilization processes are doing their optimal work, and lastly, what kind of etiquettes should the ophthalmic personnel have when they are working inside the theater. So we have with us eminent ophthalmologists who have been in doing this kind of work for with over 20-25 years experience. So Dr. Deepshika Agarwal has been responsible for introducing the first ocular modular theater, stainless steel modular theater in India, and this was not there earlier, but now a lot of in way back in 2004, and now we have, this is a much more common kind of a setup that we get to see in many places. Dr. Anupam Sahu has have over 15 to 20 years experience in running OT protocols. Myself, I'm Dr. Samrat Chatterjee, and I look after our microbiology services, doing OR surveillance for over 20 years. And at the end, we have Dr. Mihir Mishra, who is also an expert in OR surveillance, OR etiquettes, and is currently the quality head of our institute, having done NABH certification. So thank you. So the first speaker is Dr. Deepshika Agarwal, who's going to talk to us on an idle operation theater. So we'll do the discussion afterwards, after the presentations.
Thankful to AIOC and good morning, everyone. I'm thankful to AIOC and APAO for giving this opportunity, and thank you, Dr. Samrat, for giving this opportunity. This.
Please join us.
So I am talking about the ideal operation theaters, no financial interest. So why the need of ideal operation theater? Because surgical care is an integral part of any eye care system, and ophthalmitis is a most devastating complication of any ocular surgery. Surgical site infections are the second most common cause of hospital acquired infections. So every step should be taken to reduce any devastating complication of surgery. If we look at the evolution of operation theatre, it has evolved from 18th century to 19th century, and it has come from a simple room with minor equipments to packed theatre, and eventually to the sterile and special environment of modern operation theatre. This is a consequence of acceptance of germ theory of the disease that was theorized in mid 16th century and validated in mid 19th century. If we look at the historical perspective, Cataract surgery has been done in houses like couching, in camp surgery like schools, dharmshala, community halls, and hospital, primary and community centers, and other venues like train, plane, van, and ship. So, what is ideal operation theatre? An ideal operation theatre is an environment in which all sources of pollution and microenvironment alterations are kept strictly under control. And fundamental principle is no harm to the patient and surgeon. Standard operation theatre protocol should be maintained. An operation theatre should be customized according to the size of the hospital, patient's turnover, available resources, and future need. So it includes location, design, environment, equipment, and CSSD, other supplies, traffic of operation theatre, dress code, maintenance, OR surveillance, OR biohazards, waste disposal, safety measures, handling of emergency, and proper ongoing training of staff. So subsequent speakers will speak in other topics. So location should be low-rise building. OT should be separated from general traffic and air movement of rest of the hospital. So operation theatres are divided in the zones. It is outer zone, clean zone, sterile zone, and disposal zone. And according to the zones, bacteriological count progressively diminishes from outer to inner zones, like operating area, and it is maintained by differential decreasing positive pressure ventilation gradient from the inner zone to outer zone. So outer zone acts as a reception area, admission area, and accessible to all. Clear zone is comprises of changing room, patient's operation room, preparation room, and this transfer zone, and it is accessible only to OR staff. Aseptic zone is a sterile area, and it includes the space of scrub for the scrub and gowning, actual operating area, as well as the area where instruments are cleaned and sterilized. Disposal zones used linen and disposals are managed. Equipments and supplies are processed. So advantage of zoning are minimize the hospital infection, minimize the unproductive movement of the staff and the supplies and patients, increase the efficiency of operative team members, ensures the smooth workflow, decreases the hazards of operation rooms, ensures the proper positioning of the equipments. So this is outer zone, which is reception, admission, patient and patient changing area. Clean zone is changing room of OR staff, pre-op area, block room, anesthetic room, post recovery, as well as the transfer corridors for shifting of the patient to OR. Aseptic zone is a scrubbing, gowning, operation room and CSSD. Disposal, it is dirty or survey this supply room, as well as this corridor and equipment and supplies. So the design of operation theatre is the space should be in OT accommodate the needed equipments and staff. Then OT room should be minimal of 250 square feet, but if it needs the general anesthesia, pediatric and retina, then it should be 400 square feet, and if it is needed more light and other equipments, then it should be 576 square feet. And door should be of adequate width, it is 1.2 to 1.5 meter. It should be sliding with a small window on the door. The surface should be slip resistant with minimum joints. Wall should be seamless wall and washable paints. Pendants for the pipe services like oxygen, nitrous oxide, medical vacuum, compressed air and electric sockets. Lighting should be ceiling mounted and it should be 500 lux with minimal glare. UPS should be of adequate capacity for operation theatre light, microscope and machines, monitors till like generator backup comes. Audio system for recording of surgery and demonstration and teaching. The scrub area, this scrub sink should accommodate at least 2 to 3 person. Water filter, as well as the this tap should be hand or this elbow or foot operated. Water tap should be 10 centimeter of the wash basin, and adequate and continuous water supply should be in operation theatre. And environment of operation theatre, so ventilation and temperature should be maintained, because during the surgical procedure, dust particles, textile fibers, skin scales, respiratory areoles are loaded with viable microorganisms and are released from surgical team in operation theatre. The risk of infection is significant with the aerobic bacterial counts in the range of 700 to 1800 bacteria carrying particles, but it is significant when the count is 180 per cubic meter. High quality air is essential to control the risk of surgical infections. Direction of flow should be from the operation theatre to the main entrance. Efficient ventilation controls temperature and humidity in operation theatre, and separate air handling unit should be in for each theatre. The airflow should be unidirectional flow. HEPA filters have a 99.7% efficiency in removing the air from airborne particles of 0.3 micron and above by ceiling mounted laminar airflow. And the physical parameters, positive pressure system should be in operation theatre. It should be 5 centimeter H2O from ceiling of OT to downwards and outwards to push the air from OT. Relative humidity should be 40 to 60% and temperature should be 20 to 24 degrees centigrade. In one operation theatre, one operation table should be, it is 1.8 meter long, instrument trolley should be 0.9 meter, workplace should be around 1.2 meter around the table, and per operation table should be 3 set of surgical equipments. Unwanted equipment should not be in the operation theatre. And in this pre-op area, there should be monitor should be available, oxygen gas suction pipeline should be connected with the central supply, but the standby facility should also be available. Patient should have a stretcher, trolley, wheelchair and available in the pre-op area. CSSD for sterilization of the instruments, equipment and materials. At the end of the operation theatre, there should be buzzer system to inform the CSSD. This material should be go through the hatch window, and there the dirty corridor should be patrolled by the staff. Supply to the operation theatre should be from the other end, and traffic of OT should be controlled. There should not be crowd in the operation theatre. The other facilities also are important in operation theatre, like for the communication, telephones, intercom and code warning signals. Data management also important for customized network connections for the record material and management. Sterile the satellite store for the supplies, safety measures, proper place of fire extinguishers and other safety measures, restroom for the staff, changing room and locker facilities. For operation theatre, CMC and AMC also very important, and also should plan for the spare parts. Air conditioning maintenance are also very important. Dress code is also important for the staff to upgrade, because the technologies are advancing on a daily basis. So we have to train our staff for the equipments as well as the these processes. So in conclusion, ideal operation theatre can provide maximum benefit to maximum number of patients, it saves the surgeon from the stress, prevents the devastating complications like endophthalmitis, and it improves the cost effectiveness of the hospital. Thank you very much.
Thank you, Dr. Deepshika, for that exhaustive talk. We'll take the questions and discussions at the end of this session. I request delegates to please come in front so that, you can be more interactive and feel this thing. Please come and take the first row. The first row is not for any VIPs. So I now request Dr. Anupam Sahu, who will be speaking on instrument cleaning and sterilization, a area where a lot of us have lot of confusions and lots of issues. Can the timer be reset to 15 minutes?
Good morning, everybody, and thank you for coming so early in the morning. I'm Dr. Anupam Sahu, and also thank you to APO AIOS and to Dr. Samrat Chatterjee for giving me this opportunity to talk. So I'll be talking about disinfection and sterilization. So basically it includes both the instruments and our operation theatre also. I have no financial interests. Uh, so basically, we have built a very good hospital now, and we all know that it won't stand the test of time if we don't maintain it very well. And that maintenance needs to be followed according to certain protocols. These protocols have been set over a period of time, and as of now, it's a very set protocol. Before that, we need to know the definitions. Cleaning basically is just the removal of visible soil from objects and surfaces, and normally is accomplished manually or mechanically using water with detergents or enzymatic products. Disinfection is the process of elimination of many or all pathogenic or microorganisms, but except bacterial spores. And sterilization describes the process that destroys or eliminates all forms of microbial life. So we all know that for us in ophthalmology, it is only sterilization that is needed, unlike for some other specialties. So coming to the operation theatre, as we have Dr. Deepshika Agrawal has already discussed about these zones. So these zones are very important not only for building the hospital but also for maintaining them. So we already know about these zones, but then each zone, for example our sterile zone, it needs the strictest protocols amongst all. So disinfection, sterilized instruments and frequent cleaning. So anything that goes into the sterile zone should be as sterile as possible, including us. So then we come to the clean zone. The clean zone basically needs disinfection and cleaning. That is more than sufficient with a regular maybe fogging or deep cleaning on a weekly basis. Outer zone cleaning is sufficient. Outer zone we saw was the reception area and all. They also need to be cleaned properly so that no dust or mud or all those things come up to the clean zone. And then we have the disposal zone where we have biomedical waste management systems and instruments that need to be cleaned out there. So in the OT, daily cleaning is important. This daily cleaning again should start from the innermost to the outermost zone. So from the sterile zone to the clean areas, and it should start from the operating room, the scrub area, the pre-op areas for inside the OT complex, and then outside there's a separate team that does the cleaning. And inside the operation theatre also it should be from inside out. So you start with the OT table, instruments and then surfaces. Example, you have different options: glutaraldehyde, hydrogen peroxide, sodium hypochlorite based. For example, we use bacillocid extra. Floor should be cleaned the last because by that time things would have fallen onto the floor, and that should be the last to be cleaned. Wet mopping followed by mopping with quaternary ammonium compound based bacillocid floor or D125, or even 0.5% chlorine is good enough for this. UV light is switched on when the last person, UV light is again very important, it maintains the sterilization. It should be switched on when the last person leaves the OT and is switched off before the first person enters the OT, so that it doesn't cause any damage to us, and it maintains a aseptic environment in between. Weekly deep cleaning should be done on the weekends specifically, so that Sunday is there for the OT to relax as such. So cleaning of the ceiling as well as the wall mounted items, that should be done on a weekly basis. All the articles that are removed from the shelves and cleaned. So ideally as little material should be there in the OT as Dr. Deepshika has advised, but then whatever is there, for example your equipments, microscopes, beds, everything should be deep cleaned during this period, again with the quaternary ammonium compounds. HEPA filters of ACs are to be removed and cleaned with detergent solution, and they should be dried well before fixing well, because we should remember that any amount of water or humidity will predispose to any infections. Now fumigation as of now is not routinely recommended, but you can go ahead and do it. It's on a weekly basis. If you do it, it's not that much of an issue, and fogging and all is not very costly with formalin and all. But then we also use D125 and other instruments which may be costlier, but then it depends on your own setup. As of now, most of the cleaning is focused on the deep cleaning that we do. But for some circumstances, like after our construction or some renovation, after some major civil or maintenance work, or while commissioning new OT, or reporting of any infection in OT or culture report. So whenever Dr. Samrat will be telling us about the culture and all, so if you get something positive in that, then we again need to do a fumigation for that OT and then get reports on that. So these are the different options that we have: Bacillocid, Resent, Virkon. These are costly. Formalin, hydrogen peroxide, combination of silver nitrates, they are cheaper than that. So as I said, now stress is more laid on cleaning of OT floor with antiseptic solution or disinfectants, but even doing this won't be harmful to us. Coming to the instruments. Now instruments are something that go into the eye, and that is where we are more concerned about endophthalmitis. So, and also TAS, because one is infection because of external organisms, one is the infection that make inflammation that we cause to the eye, and for that we need to ensure that our cleaning processes and sterilization processes are good enough. That is one of the major causes of toxic anterior segment syndrome is when residues are left behind. So we need to ensure that our cleaning system is very proper. So other things are also there, your the fluid that you are using and all, but what is in our hand is we need to ensure that our cleaning and sterilization process is perfect, so that there is no remnant residue on the instruments. So these are the steps basically that we should be doing for instruments. Inspection, you should see whether there is any blood clot or anything. Cleaning, drying, storage, packaging, sterilization and documentation. I'll come to them. So after surgery, each instrument from the set should be carefully scrutinized for defects, debris, anything, or as the doctor would have suggested at that time. Do not allow, so this is very important for the staff, that you should not allow any tissues, blood irrigating solution, viscoelastic medicines. Viscoelastics also stick, and then it's very difficult to remove them once they are dried. And especially in cannulated equipments, if that cannula gets stuck with visco, you cannot remove it then. So they should be cleaned immediately at the end of the surgery. So this is how the instruments are being cleaned. The blades are cleaned, and cannulated instruments should be flushed. For example, your phaco probes and all, they should be immediately flushed immediately. And these instruments and then washed under running water. So they are taken out from the waste corridor, and they are then cleaned in the CSST. And later on, the cleaning by 4-bowl technique or ultrasonic cleaner. Okay, so this is the cleaning that is being done in CSST, followed by the 4-bowl technique, or you can also use. So this is basically the most important thing, the 4-bowl technique. So instruments are double dipped in chlorhexidine and cetrimide solution, 2 trays for cleaning, and then distilled water, 2 trays for rinsing, so that no residue remains. Tray 1, 5 minutes, that removes the major debris, but then whatever is remaining after that, that will be disinfected with the tray 2. Then you go to the tray 3, where you keep it for 10 minutes, and then tray 4 again 10 minutes. So at each level we are processing the instrument. So first 2 are for disinfection, and the next 2 are for the cleaning process. Instruments are then placed in chlorhexidine and cetrimide solution in tray 1 and 2, and thorough cleaning is done with the help of a toothbrush. So for serrated instruments and all, we need to clean them with a fine soft, super soft or soft toothbrush, so that they can be, debris can be removed without any damage. So the serrations and the joints and locks are very important places to be cleaned, because otherwise they get stuck, and those are the places where the debris again leads to earlier damage to the instruments also, and because these are the places where the corrosion will also start. Enzymatic cleaners as of now are not preferred for ophthalmology, but then for some conditions like oculoplasty, or where there is significant bleeding, in those cases we can use rapid multi-enzyme cleaners by 3M, which is 10 ml of the enzyme in 990 ml of distilled water. It's placed in the solution for 8 to 9 minutes, and then it's again important to rinse and dry the instruments well, because these again can lead to, so that's why they are not preferred nowadays, because incidence of TAS may increase with these cleaners. They are very strong. Ultrasonic cleaner again not very preferred, but then for again cases where you have lots of bleeding and all, where you can use them, but then they can damage the instrument also. Make sure that the instruments do not touch each other when they are kept in the basket, so that they are not damaged too much. Now coming to the drying part, which as I said is very important, because humidity will lead to immediate onset of growth of organisms. The instrument should be dried by aeration or hot air. This is very important, so that no humidity remains on the instruments before it goes for sterilization. It should not be wiped with a cloth or something, because that will again lead to removal of the surface coating and blunting of the instruments. Storage, surgical instruments are usually stored as a set. We know that. So each cataract set and instruments belonging to one should be kept in their respective trays only. That should be something your staff should follow. Trays and instruments can be marked in similar codes so that they are not interchanged. And pointed tips and blades and scissors should be kept in the plastic sleeve, as we can. So your silicone or plastic sleeve can be used. For moving parts, we can use lubrication again before it goes for sterilization, only when you feel that there is significant limitation of movement of your instrument. So surgical grade silicone or Teflon spray should be used, but not normal lubricating oils, because those oils will remain on the surface. Again, packaging for sterilization is very important, because if we don't do a proper packaging, there can be immediate reinfection in the our sets. So all instruments need to be packed before sterilization, and this is the double packing method for steam autoclave, where we use double packs. The first pack is the one that becomes contaminated, and then the second one is given to the assisting nurse to open up on the sterilized area of the OT. Okay, and in the OT also you should have a sterilized area at the head part of the OT table. So that's the part where nothing, even clean or not very dirty thing, should be remaining for long. And for ethylene oxide also, we have ethylene oxide gas sterilizer, and on that we can use the bandages, iPads and all, and again instruments, if you are trying to reuse them, they can be used, but then it should be cleaned properly. And packing should vary as per the specification of the instrument maker. Coming to disinfection and sterilization, we already know that for us sterilization is the most important part, because we come in contact with sterile tissues and blood systems. Disinfection is not recommended as of now. Sterilization, different types. Sterilization under pressure, that is autoclave. There are different types of autoclaves now available. It is dependable, non-toxic, inexpensive and sporicidal if done properly, and can penetrate fabrics well. Dry heat or hot air oven, it's done for articles that can be damaged by steam, sharps, oils, ointments, etc. And ethylene oxide, it provides low temperature sterilization for heat sensitive. For example, iPads and all them you can do on ethylene oxide. So there are different modes basically. Now we have lot more machines which have lots of varieties. They have 2 modes, 4 modes and all. But then basically if you are doing it at 15 psi pressure, then temperature usually goes should be at 121 degrees centigrade, and time should be around 30. If you are going to do it for fast, then 30 psi, 134 degrees centigrade, and for 4 minutes. And it's also important to remember that you should use them for ideally 48 hours and not later, because then the sterilization may be compromised. This is the whole cycle of a steam autoclave, and this is the ethylene trioxide gas sterilizer, and these are the things that can be sterilized with it. This is the EO gas sterilizer that is placed in it along with a this is the dosimeter that identifies whether the sterilization has been done properly. It's important to remember that the EO gas is toxic and potentially explosive, and due to its toxic nature, do not use these instruments immediately. They should be used after a aeration period of minimum 72 hours. A microbiological control is mandatory, and EO gas sterility can be maintained if packed properly for 1 year in original packing. Indicators we use, just a few minutes, 1 minute more. It measures the efficacy of the sterilization procedure and helps to keep a record of the sterilization. So these indicators are important. There are different types. So we use different types of sterilizers. So thank you, everybody.
Thank you, Dr. Anupam. Now we are completed the sterilization part. Now once the sterilization is complete, now we have to validate, or we have to see how much the sterilization process is effective or it is foolproof. So next talk is on Operation Theatre Surveillance by Dr. Samrat Chatterjee. He is the Infection Control Committee Chairman in our hospital, which is runs under the NABH. So his in-depth knowledge about the surveillance part, how to validate the processes which has been done. So over to Dr. Samrat.
So I would like to at the outset thank AIOS and APO for accepting our instruction course, and thank you, Dr. Meher, for the generous introduction. So there's no financial interest in any of the material that you see out here. So we all know that we need to prevent post-operative site infection and for ophthalmology, acute endophthalmitis. And for that is the primary goal of entire theater. And as you have seen that it starts not after the theater is built, but it starts before the theater in designing and also on the general practices. So surveillance is a continuous process, and when you act upon the information and analysis of the data that you get from your monitoring, that becomes surveillance. So surveillance is an active role that an ophthalmic surgeon has in preventing acute postoperative endophthalmitis. So whenever you have a new facility, one should do an OR surveillance on day 1, day 2, day 3 and day 4. So this cleaning and fumigation should be done and you should get these 3 non-significant reports, and I'll tell you what a non-significant report is. But once the facility is built or after, then it should be done. There's no fixed guidelines for it. So depending upon the resources that you have, it can be an expensive process. You can do it either fortnightly or at least once a month. So that is important to do it once a month in an existing facility. So OR surveillance can be done by anybody. You can train your OT nurse, OT technician to perform, or if you have access to a microbiology lab, then their staff can also do the surveillance. For the surveillance, you need sterile swabs that you can see out here. Then you need a liquid media. Then you need some solid plate like blood agar, chocolate agar and STA, and you also need some biomonitors. So the sample collection is usually done the previous day. One does the deep cleaning and fumigation if you are doing fumigation, and next day early morning before the OT starts, before people enter the OT, you need to do the sample collection, and you need to label all the sterile swabs that you take, and then you need to moisten the dry cotton sterile swab in the liquid media and then use it to take the sample like it is shown out here. So you can see that you take it from the wall. Which wall? You don't need to take it from all the 4 walls. You can take it from the wall or the head end from the surgeon. Secondly, you need to take it from your AC vents and AC ducts, from the head end of the OT table, then from the handles, from your OT trolleys, and where you are cleaning your hands, you need to take the midstream from your water supply, water source. There is also, you need to monitor the air also, the air quality. So air quality, there are some specific equipments out here, but most commonly that is done in most of the center is this settle plate method. So before you start doing, after you have taken all the swabs, what you do is you open a petri dish of blood agar and seborrheic dextrose agar that you can get from your laboratory, and you just keep it open for half an hour, and after half an hour you close it, and then you can start the OT, your routine OT. There are some specific formulae for this thing, calculating your bacteria carrying particle load, but the most dictum is that if you have more than 10 bacterial colonies in your solid media plate, it is significant, and if you have even a single fungal colony, that is significant. So more than 10 bacterial colonies and 1 fungal colony, that is the dictum or the rule of the thumb that you need to follow. Then when these samples are collected, of course this part you are not directly involved, it's your the laboratory services, so they will incubate it in proper temperature and air system. Then Dr. Anupam had briefly alluded to you about the indicators. Now there are 6 classes of indicators, class 1, 2, 3, 4, 5, 6. It doesn't mean that 6 is better than 1. Each of these measures some specific processes. Of these you need to have 3. 3 is the minimum. First is this signal lock or indicator, which we all are familiar with. It just turns color and tells us that it has been exposed to some steam or something like that. The second is you need to have the bovidic. This is the bovidic. This is a bovidic that you get, and after sterilization it changes color. If it doesn't change color, that means the steam penetration within that load is inadequate. And then you need to have either a 5 or class 6, because that assesses and validates your cycle time of your sterilizer. So, and these are very simple to interpret, like in this class 5 you can just see that there is a gray line. If the gray line goes into the green zone, that is the pass zone, that means your sterile process is effective. And these are the class 6. So you need to have 1, this is mandatory, this is mandatory, and this. So this goes for each equipment, even a single pack of a swab or a reusable blade, you put this. This goes for the entire packet. So if you have a tray, you put this on it, and this you do once a day. Once a day in the morning, you run the Bovidic, that it comes in a pack. You put it in your sterilizer without anything else, without any other load, and you let the sterilizer complete its cycle. Take it out, remove the sheets of paper, and then see whether the color has changed. If the color has changed, that means that machine, that autoclave is good enough for the entire day. Then you have biomonitors. So you need to also to do a biomonitor test, and this doesn't need to be done daily. You do it once a week. So if you have a EO gas also, so the EO gas and the steam autoclaves, they have different biomonitors. And both these biomonitors are placed where? They are placed at the most central part of the load, where the steam or some steam and would would have the most difficulty in penetration. And once you put this vial inside the load, get the sterilization completed, and you take it out, then there is a small ampule out there. So you see this blue media, so that is the media, and inside the media there is a plastic ampule, a glass ampule. So you squeeze on the glass ampule, and the spores that are present within the glass ampule will come into the media. If your sterilization process is good, that means all the spores would have been killed, so there won't be any change in this media indicator. However, if there is a lapse in this sterilization, the pressure has not reached, or if the steam has not penetrated, then the spores would not die. So once you crush it and incubate it, then the spores would turn into bacteria, and then you'd get a color change. So you just need to see for the color change. However, just doing this is not enough. Although this is not the microbiological surveillance, this is a operation room surveillance. So you need to check all your equipments, like you go to the your block room, see if the drugs that are there have not expired. Each of us should have a use by date policy. So see if for example Apidin and all, you should finish it off in 24 hours. So see, check all the days, expiry days, when it has been opened. Then you go into the operation room, and then you check for its systems. Go into the sterilization room, look at all these records, the biomonitor, the indicators, whether they have changed color, whether your OT staff is making a note of the the load, that each load contains which trays and which tray has gone to which OT, if you have more than one OT. So all those things are need to be done, and you need to physically inspect your the area. See if some of these windows or things, they don't the linings, the silicone linings that are there, if they have not come out, if there is a seepage somewhere, a damp spot somewhere. So this needs to be a daily process. And if you are in a single setup, you are the person responsible, you are the master of the ship, and this you have built. So you are responsible for it, and you need to see it every day, like we check our own home. As a professional, our OT theatre is part of our home, the sanctum sanctorum. And then you need to maintain all these registers. They should be kept, so you need to monitor it, and you need, so this has a record, and then it can tell you about the pattern of how your systems are working. If you are the sole person, you don't need a committee, but it is better. But if you have multiple people, you should have a committee which should take decisions whether you need to change from one sterilization system to the other, change a disinfectant. If a disinfectant is out of the market, then other substitute. If you are getting more number of bacterial colonies, try to find out a source. So if you have 2 or 3 people in the community, the surgeon, the administrative head, and a microbiologist, it helps you to identify any lapse in your system. So the take home message is that surveillance is a daily daily business for us, like we come to the OT, so you should have someone do a daily surveillance. If you do the surveillance, then whatever processes you had implemented you'd be sure that they are being carried out. And as the first picture, most of you have not seen the first picture, that post-operative endophthalmitis, you can prevent that. Thank you. So the concluding talk, we'll take all questions at the end. So I invite Dr. Mihir Mishra, who is the quality head of our institute, to talk about OT practices. So you first build it, then you clean it, you surveil it, and lastly you behave properly in it. Because if you have everything but our behavior inside the etiquette inside the OR is not fine, everything will fail. Dr. Mihir.
Thank you, Dr. Samrat, for inviting me for this IC. And thank you, AIOS and APAO, for including this IC in the conference. And welcome, delegates. Good morning. So I'll be dealing about entry to exit. Means whenever you have a OT setup, entry means you have to enter inside and do the work and come out of it. So whatever goes inside the OT, that is the processes, and whatever etiquettes you have to follow in the OT, that is the paramount importance, because until unless every process is made, but if you do not follow or do not strictly adhere to that, then it is a waste for it, and it will breach the sterilization and other processes. No financial interest. So operation theatre is a complex working environment where technical and non-technical skills both converge, aiming to maximum efficient outcome of any procedure done. So it has skilled personals and non-skilled personals also. In traditional medical curriculum, technical development is emphasized and non-technical skills, mostly the soft skill, which is important, which governs the surgical outcome, is basically overlooked. So we have to make emphasis on the soft skill of the staff which is associated with the OT. The processes includes the technical processes, that is the instruments, equipments in the room, which requires all the sterilization processes. Next is the organizational workflow processes, that is the workflow time, methods of work, and the standard operating procedure which we have laid down. And the social process, that is a soft skill which is important, which is very much important for the coordination. So that is the knowledge of the OT part and what is used in that, the skills, the attitude, the motivation, and the level of cooperation. So why there is a need? Of course, these are all relating to the OT, which is a very sensitive area and the heart of the hospital, and it is relating to the infection, it is relating to the contamination, biological contamination, and any mistakes or wrongdoing will lead you to court and you will be finished. So surgical and anesthetic accidents may occur if you don't have a good infrastructure or not properly handled, and 2.5 of the all surgical patients have some acquired wound infection, that is a surgical site infection. So any eye infection can culminate in extremely devastating consequences for the surgeon and also for the patient. So for that, better to have a standard operating procedure, whatever way you have, but you have to lay down a single procedure for all the staff and also for the personals who enter into the OT, so that they know in and out of what is the processes which has to be done inside the OT. And that is a vital component in any quality management system. You have to have full compliance with guidelines and regulations, mirror current organizational practices, and what it helps in, it decreases variation in care, it improves the guideline compliance, and improves the overall quality of care. So coming to the standard OR etiquettes, now minimum infection prevention practices that apply to all patient care, which is regardless of suspected or confirmed infective status of the patient in any healthcare setting. And second is to protect the healthcare professional from getting infected, as well as to prevent the personnel themselves from spreading infection amongst patients. So these are two parts, one is the patient and one is the staff. So there should not be any exchange or any transfer of infection from towards each other. So what are the people who are involved in this? Those are the surgeons, the anesthetists, the scrub nurse, the circulating nurse, the assisting surgeons, the OT technicians, and the assisting paramedical staffs, and the other staffs, whoever, if at all you have. So coming to the most important part is the soft skill, because until unless you have the etiquettes, then everything goes waste. So this includes the honest qualities which I will be dealing about. Knowledgeable, he has to have complete knowledge of what he is doing and where he is there. Physical stamina, he should be well, of course, fit enough. Emotional stability should be very much in good emotions. And dependability, patience, sensitivity, understanding, responsibility, good judgment, good communication and interpersonal skills, most important here for coordination. Cheerful and practical, caring for people of all ages, that is patient care and also the care of your peers. So these are the 10 points which I have shown, which are paramount importance and minimum these has to be followed. Time management, communication, adaptability, problem solving, teamwork, creativity, leadership, interpersonal skills, work ethic and attention to detail. So of course we have variation in our own nature and characters of everybody, starting from the low to the up, including the surgeons also. So we have a stereotypical surgeon personality. So these are no's which I have crossed, and the other part is decisiveness, the well organization amongst the persons and the patient and the staff care, the practicality of work and the hard working. You have to be hard working, of course. And the assistants, mostly they have to have understanding, perception and familiarity, because this is basically a teamwork. So everybody has to know the other person and his needs, because it should be a very smooth flow rather than having a very miscommunication or any sort of a problem inside it. So coming to the general OT etiquettes, we learn about the operation theatre zones, which are already told about. So SOP has all these things included in this, the sterilization, the zones, the sterilization zones and the other part. So they should be well aware of it. The healthy and safety information, the compliance and the response etiquette to capacity building and the efficiency enhancement of the team. To be familiar with the WHO surgical safety checklist, which we have prior taking to the patient in the OT. There is a checklist. We have to see the right side, the right procedure and other things which are to be mandated before the procedure. Identify and deal with hazards in the perioperative environment. Acquire proper knowledge on infection control, hazard substance, smoke, plum, gas, lasers, sharp safety and associated injury, risk assessment, PPE requirements, manual handling, waste management, damage to equipment and building, fire safety, stress and equipment handling. So these are all important aspects which is dependent on the type of work you have and the area which you are designated. Coming to the other part, so this is basically personal part, which personal belongings like bags, cell phones, laptops, jewelry, wristwatch, anything extra from you should not be entered into the OR. Abide by rules related to access to information and confidentiality. The patient MR numbers or any sort of information should not be breached to anybody else, mostly the patient attenders or anybody. The photography video without permission we should not do. So we should have a consent from the patient also that we will be taking the photographs or videos, and it will be used for further purpose or research or any educational purpose. Then give value to privacy and dignity of the patients. Sign the attendance visitor book as per the norms of the given OR. Then of course behave professionally, arrive before time, change street clothes with proper attire. Then healthcare workers, observer or support staff including the surgeons also, be silent and modest, ensure responsible and respectable communication, be sure that you are in good health and report to in charge if unwell, be silent and modest, and always ensure responsible and respectable communication. So these are again I am emphasizing because this is most important. Now coming to the other part of it, the actual going into the OTR, main OT. So know the details of surgical scrub, the duties, the limits and responsibilities of scrubbed and circulatory personnel, not to touch any sterile equipment and personnel already scrubbed and gloved, and only scrubbed personnel can be in the sterile zone and other will be in the circulatory zone. Be familiar with the WHO surgical safety checklist, which is already available in the net. Now coming to the surgical attire, it is mostly referred to the clean and sterile clothing worn in the OT to provide effective barriers that prevent the dissemination of microorganisms to patients and protect personnel from any blood or body substance of the patients, vice versa, which you call. And that includes the personal protective equipment, that is the mask, the cap, the scrub suit and the gown. So these are components of the PPE. There's the scrub suit, which designed for maximum skin coverage, which has a potential source of microbial contamination. The caps, head and the facial hair should be covered, of course, whole of it. The masks are mostly disposable, well-fitting deflector are worn, and cloth masks are, of course, ineffective barriers for microorganisms, should not be used exactly. And shoes, dedicated footwear is recommended for use in the OR. Slippers will be different for the toilet use, and it should be kept separate, and it should be daily washed with detergent and dried. The sterile gloves, of course, are worn by all the scrubbed members of the surgical team and should be changed after every case. The gowns and drapes, these create a barrier between the surgical operative field and potential sources of microorganisms. So they are ideally made of material which is impermeable to liquids. So disposable drapes are also available, gowns, so that can be also used if feasible. So preparation by the OT personnel: have a good meal before entering the OT and empty the bladder, so you are not in a hurry to go somewhere else during the procedures or during the your period of work. Switch off your phones and keep them in silent mode. Remove your jewelry. Make sure you go through the patient's medical records about the surgery beforehand. Wear the OT gears. Confirm the patient identity before shifting patient to OT. Cross verify if the procedure consent is signed before the patient shifting. Then ensure patient dentures or movable artificial teeth which are before the shifting the patient, because this is during the anesthetic procedure, it is very important. So you have to just inform the patient or the attender mostly if there is any problem, or you foresee any problem during the anesthetic procedure. Mark the surgical site and side before patient is shifting in the OT. So coming to the preparation for medical personnel, you should have punctuality, alertness, use of sign language, phonation and language, because you cannot just have a straight talk when the patient is on the bedside and he is hearing everything on you if it's a local anesthesia. So be wary about it. Administrative skills has to be there with personalizing and preparation of self for surgery. You have to prepare yourself for the surgery. You have to know what to do, plan it before. Identification and consent of patients should be seen actually, and use of cell phones within the OT should be restricted. So decontamination, surgical hand washing is required before performing in surgical procedures. So all ornaments should be removed from the hands at the time of scrubbing. The quality of water should be lukewarm water, and it should be like AquaGuard can be used for that. We have dispenser which may be automated or it may be a manual one. Then hand washing and arms are 2 inch above or below the elbow, and clean fingernails under the running process. We have all the various types of cleaning instruction which is standardized here. So this has to be followed, and this should be always put near the wash machine or the scrub area, so that the person can see and he can follow those steps for hand scrubbing. So chlorhexidine or povidone 10% can be used, and hand are dried before donning the glove. Coming to the OT inside, the proper downing has to be done for the gloves, and we should not touch anything other than the sterile instruments and operating field with the gloves. And do not come out of the OR with the gown and the gloves in hand, and disinfection of the hand before or after downing is the rule. So this is how you take out the sterile packs for the gown. So processes may be different for you, but you have to have the sterile chain which has to be followed. So it's not exactly that you will do the same thing, but ideal you should follow those things which help you in giving the sterile maintenance towards it. So these are no touch. Once you have inside the OT and you have wore the gown, there's no way in touch to anywhere else. Now inside the OT, follow the correct gowning and gloving already done. The back of the gown area, which is the area of the breast, should be considered unsterile, so you should not touch anywhere. The gloved hands are kept above the waist on the top, and the sterile field and clasped in front. So coughing, sneezing are avoided, and if you have something, you should go in the other side of the or make a sidewise movement. So again, this process of gowning depends on your type of OT gowns which you have. Now these are of course not the right proper way to stand inside the OT with all the surgical attire. Better to avoid it. Now, circulating ONA in OT, you have to have the hands must be kept behind the backs. Do not touch or lean over the sterile field. Do not pass item over the sterile field. And check sterility expiry date of each pre-sterile pack before opening. And sterile item is not used immediately, should be kept covered. While pouring liquids in the container jar, you should hold 6 inch above the sterile field. Now coming to the role of the scrub nudge, which is very important. So quick reaction, anticipation and conscious observation should be there, because you have to coordinate with the surgeon. So draping and trolley preparation is most important, properly done depending on the surgery which has to be done. So limited mobility of scrubbed person, maintenance of instrument and equipments, and suction cautery tubings and other connection has to be properly placed. So good habits in OR is limit the number of people who enter the OR, clean and disinfect all the horizontal surfaces after
Dr. Mihir,
each
you
case.
need to wrap it up.
Yeah, just 1 or 2 slides. Avoid hurried action that might distract surgeon and patient. Assistant should face the surgical field area and closely watch the surgery, and scrub personnel should pass each other to back, and no unnecessary change of assistants. So these are all important for observers also. So they have to be in proper way. Crossing between sterile field is avoided, and there should be a 1 foot clearance. Woolen wares and other to be avoided in here. And because there is a CCTV, you should not have any crowding, or you should be properly maintaining the etiquettes. So patient with HIV, HBV, you have to have important care, and you should have extra barriers for that, which is laid down in the protocols. And you should basically have a color code in the patient file, so that it can be identified by all staff, and they should take the proper precautions for that. Documentation, you have daily OT checklist, daily OT reports, which has to be maintained, so that you go along with the processes. There should not be any breach in the processes. If there is any there, then it should be taken care of immediately, or the day which is done. So on the backdrop, the surgeon is accountable and responsible in the court of law for whatever happens in the OR. Proper SOP with adherence can efficiently reduce the adverse events and can improve the outcome. Enhancement of the teamwork, performance and commitment can be done by behavior management, and it is important for safety of all, which is achieved with barrier and prevention by complying to the etiquette norms. So these are some guidelines which are there, and you can also refer to that. So that has all the details also. Thank you.
Thank you, Dr. Mihir. So we have a good 15 minutes before the session ends for questions. So you can ask questions to anybody at any time. There are microphones ahead, so you can come and ask questions there. And I'd request the audiovisual person to please put up the handout photograph behind.
Hello.
It has a QR code where the presentations are uploaded there. Please put up the first presentation. 1. So that's the QR code. Yes, sir. Please go ahead.
So my question is related with the hospital-acquired conjunctivitis, how to prevent them. A healthy patient comes for a general eye checkup or for OT dates, and he goes back sometimes with the conjunctivitis. So what are the precautions or any disinfectants methods which we can take? Like the patient become and doctor also become apprehensive when post-operative they catch conjunctivitis, or pre-operative also. So what are the precautions or methods or things which we can take care to prevent?
So with conjunctivitis, if it's like a single case that comes to you, because you can do the triaging in the during registration, any acute red eye, your registration staff can identify that, then you can isolate there, but that doesn't happen in a busy OPD, and usually the diagnosis is when you diagnose it. So the moment you diagnose it, then you should ask your primary person who examines it, if you have optometrists or vision technicians, and if they come and tell you that there is a suspected conjunctivitis, you should avoid any contact procedures, avoid fundus, avoid refraction, and see the patient, give priority to that. Once you see the patient and give the management, you clean the entire slit lamp and the tabletop You can use isopropyl alcohol or any this thing disinfectant. Wash hands thoroughly. If you can identify which chairs that patient has sat, you can clean that also. But the second part becomes difficult. Secondly, if you encounter, like we have these outbreaks of conjunctivitis, if you have outbreaks of conjunctivitis, then you know that an outbreak is there. So in that case, if you have facility, you can keep these patients in a separate room, inform your registration staff that if a patient comes with red eyes, swollen eyes, discharge, that they should not be kept in the general waiting area. Some of these viruses, they can persist on tabletops and plastics and metal for 1 to 2 months. So that you can use any this thing. And for most of the viral, this thing, a simple soap hand wash is good enough. You don't need to use hand alcohol based hand rub.
And your staff should also be aware that if they have red eyes, they should immediately show themselves, and maybe if they are especially the OT staff, then they should be taken out of the OT that day.
Good morning, sir.
Good morning.
My question is regarding the sterilization equipment. So I wanted to know, in this day and age, if someone is using a hot air oven for instruments that can be placed in that, is that still acceptable? And if yes, then is there any way to validate it? Like we have the integrators for the steam autoclaves. Is there a way to validate the hot air oven?
I think I'll ask Dr. Anupam to answer that.
I don't think so. So that's why today you have different types of autoclaves. So I think autoclave should be preferred.
Hot air ovens are not a part of sterilization of ophthalmic equipments. The hot air ovens are only for glass, and that you do it in a laboratory. So you should not sterilize anything with a hot air oven. Hot air oven indications are different. They are not for ophthalmic OT instruments.
One more question I'd like to ask. If, like how they talk about a Class S and a Class B autoclave, if someone is using a machine that has a reusable phaco pack, then do we still need to opt for a Class B autoclave? Or if we have a Class S machine like a 1321 Hanshin, is that enough? Or do we need to upgrade to a Class B?
I think that will depend more on your load. Basically, the classes are not regarding the autoclave amount that is being done. All autoclaves will sterilize your equipment. Class S basically does not have the pre-vacuum.
Yes.
Okay, Class B has the pre-vacuum. So what it does is it quickens the time, shortens the time. So that is the main purpose of that. So the costlier you go, the more these machines will do all these things better. That is the only thing. Otherwise, any class is better as long as you are just using indicators to confirm.
Thank you.
So the one that you're using is fine enough if you have a smaller load.
Yeah.
But if you have less packs, then you need to have these flash autoclaves. That is the.
My question was in the sense that a Class S does not pass the helix test. But if we go to a Class B, the PCD passes. But do we need to pass the PCD if our machine is like an Alcon Legion where we don't have a reusable tubing? Do we need to care about that, or do we still should go for a Class B?
No, I think I would have to look into that actually. So
The helix that you're talking about, that is for tubes.
Yes.
It was not there earlier.
Yes.
It is there right now.
Yes.
So it is, if you are going to use those tubings, you need to have, ideally you should have a helix this thing, and you should get it passed. Yeah, Ayan.
Yeah.
Thank you.
Class B is basically meant for hollow instruments. So irrigation aspiration cannula is a hollow instrument, so Class B is that way necessary.
So that PCT, you need to get it done nowadays at least, if you're reusing it. Any more questions?
While doing fogging, it is spilling on the walls, and while doing fogging, and is it completely avoidable, sir? Can we go for, some people are keeping formalin in the chambers and keeping on the four edges of the OT and leaving it overnight. Is it like anything helpful, sir? And for air sterilization, sir, main purpose for air sterilization, we are using fogging and keeping the formalin in that machine or bacilloid, sir. It is causing the spilling out on the walls completely, and some people are telling on using like that, that phaco machine ka motherboard, it is causing damage,
Yes.
they are telling, sir.
So basically what happens is if you are using anything other than formalin, we have also tried others, bacillocid and all. So if you do with them, so sometimes you will have rusting if you have your steel steel OTs, and again instruments also can get rusted with that. So that is an issue. So that's why many places have done away with fumigation. That's what I was this thing. If you have a good cleaning protocol, deep cleaning protocol or sterilization protocol, then you actually don't need to go ahead with the formalin this thing. But if your OT is not very perfect, as Dr. Deepshika had said, then it's always better to go ahead with the formalin this thing. But again, keeping it on 4, this thing would not work. Then you'll have to, then maybe there's something in your machine, because as such there should not be no spilling from the machine as such.
Okay.
So it just gives the fog.
Either you use a fogger or you use the old method if you are doing with formalin, right? But bacillocid you cannot keep. There's no point in keeping bacillocid and formalin separately. That doesn't work. Fumigation is off now. Current recommendation doesn't talk about fumigation. It is deep cleaning. So you use a deuteraldehyde based disinfectant for deep cleaning, that is keep surfaces and walls. You need to do that.
And only this deep cleaning along with that UV light is enough for daily, sir, complete? Okay,
Is,
sir. And for
good enough.
mega wash also, sir.
What?
At mega wash time also, fogging is required, or these two, deep cleaning and
At what time? I did not get.
weekly once mega wash.
Okay, the deep cleaning.
yeah,
Deep cleaning.
Again, deep cleaning, fumigation is not a part of anything as of now. Okay, you can leave it, but as I said, if you have some, if your OT is not perfect, then it can be used as such.
Okay, sir. Thank you.
Your mega wash should be once a week. Deep cleaning every day. So any more the same questions? So sometimes what you call now the bigger institutes or even the modular OTs are in place. So suppose one doesn't have a modular OT, then is modular, or let me rephrase my question: does all ophthalmologists need to have a modular OT?
Okay. Actually, modular OTs are not required. It is an ideal operation theatre. So ideal operation theatre means its construction like wall. If it is not of steel made, so it can be these tiles or pane, but there should be less joints and it should be washable. The same is important for the temperature and the ventilation, because those are the things which should be. So if you have more operation theatres, so air handling unit should be separate, and the temperature and humidity should be maintained. So that is ideal. So modular theatres are not required.
So modular theatres are not mandatory. Then, madam, can I ask you, is air handling unit mandatory for all OTs?
The idea is that air should not be mix or of all theatres. So then you feel keeping the theatres with the split AC. So there the air handling units are not. But if the central air condition is there, then air handling unit should be separate.
So with air handling unit and the air handling unit and HEPA filter. So these are two important components, desirable. But if you cannot have that, and most of us in smaller setups have to do with split ACs, you can use dehumidifiers, because you need, so that is also an important concept. So you have to have your humidity less. So how many of us are using split ACs and dehumidifiers out here? So most of us are using. And do you all do a air culture maybe once a month? And are you getting any colonies in that? So that also works. While it is desirable, you can get away with split ACs and a dehumidifier.
Of course, the ideal is HB, what you have, the heating ventilation with the air conditioning. That is called HVAC. So that is the ideal thing, which has a air handling unit, which have the heating part also, cooling part also, and it has the humidity control in that. That is the modular theaters have that basically, and each theater should have its own separate unit of AHU rather than having a common one.
In some setups, Dr. Mihir, sometimes we do an OT, then we go to the OPD. So, what precautions should we change our scrubs every time we go out outside the OT into the OPD to see a patient and come back? How do you give a recommendation on that?
So it's all depends on what areas your OPD and OT is. So ideal will be always to change it and then go to the OPD, because it's a non-sterile area. Naturally it's a clean area maybe, but it's a non-sterile area, so better to always change the OT attire and go to the OPD, do your work and come to the OT again. So never go with your OT dresses. That is ideal.
So just recently by a OT designer, I was advised that the CSSD, or like more like a TSSU unit for a single practice setup, it should not be in the same complex as your operation theater. Is there any rule to that? Because they suggest that you should place it on a different floor, but then that makes it even more difficult how your staff is handling stuff. If they are inside the complex, then they are more under your vigil. But if you keep it on a different floor, then you have to.
Basic idea is like the supplies which should be separated from the dirty corridor and the main supply. So if you are CSSD in operation theatre complex, but the supply, because the CSSD is catering both, like taking the unsterile material also or giving the, so the entries should be separate. There should be the service corridor, and the material which you want to supply, that should be from the other door. But under separate, that is for the multi-specialty hospitals, or you have a lot away and you have a connectivity with the some trolleys and all, then this CSSD is in separate.
So the answer is no. So you don't need it. What you should not have sharing with any of the OT wall or ceiling is a bathroom.
Yeah.
Right? A toilet, especially if it's tiles, you should not have that.
Thank you.
Why did they say so?
So I think we are at the end of this session, and so is there any last this thing, or anyone would like to give a comment? Any last questions? Thank you all for sure.
Like HVAC, as you said, it should run 24/7. Basically, when you are leaving the OT, you should keep it on in night mode. The air conditioning is not there, but the airflow should be continuously there. Otherwise, it might get pent up with microbes.
So there was a very interesting talk yesterday from Hong Kong, where they said that the UV lights, they should be in such a way that they don't come out of the light doesn't come off the theater, and every time one should close it. So that kind of barriers we are not thinking about.
No, basically UV lights are there inside the channels.
Inside the channels,
Yeah.
but they also are coming out of the OT theater, the windows there. So they were saying that photokeratitis has happening in some places, especially after this COVID. So that was in Hong Kong. They had an experience from the UV lights. You keep it on, but
Basically, those lights are there in the pass boxes. So
yeah.
those pass boxes have a glass which does not allow UV to penetrate.
Yeah. So that's what I was saying out there. So one should, if you are using UV light, you should also have the protective mechanism so that there is no.
Previously, that is before the modular OT, you have a UV light, and one day they forgot to switch off, and they have a photographic.
It is. Thank you all for joining us on a Sunday morning at 8 o'clock. So thank you all.